A ver, pues, video game. Audio, audio. Everything. Today I'm going to present living in petrol department and of month January 2026. This is the outline of today's presentation. Last month OPD and procedures performed in January 2026. Data, morbidity, two cases in morbidity and mortality. Uh, Data of January 2026. New admissions were 820 and new cases in OPD were 7,727. Monthly average in 2025 was 723, 6,767. This is the data of last 1 month of procedures performed in endoscopy. Upper GI endoscopy was done of 858 and ESP or EVL was done around 220 with ERCP of 81 and other procedures. First is of Mr. D, 25 years old male, presented with chief complaints of fever for 2 days, 10 days back, jaundice of 10 days with altered sensorium of 1 day. Patient was apparently well 10 days prior when he developed acute onset jaundice associated with nausea, progressive drowsiness over last 24 hours. There was no history of prior liver disease. There was no history of chronic alcohol intake, any long-term hepatotoxic drugs, or blood transfusion, or similar illness in past. On examination, his heart rate was 88 per minute. Blood pressure was 122 by 68 mmHg. Respiratory rate was 18 and saturation was 100% on room air. Patient was drowsy, not oriented to time, place, and person. Pallor plus icterus was present. Liver response was of 13 centimeter. There was no spleen, palpable spleens. Initial investigations, CBC was hemoglobin of 10.4, TLC were 20,000 and platelets were 4 lakhs 73,000. LFT total bill was 34.27 with direct of 17.2. AST was 1,921 and ALT was 1,168. KFT was normal. Initial INR was 2.1 with ammonia of 224. First ABG was pH of 7.47 with PCO2 46, PO2 of 115, bicarb of 33 and lactate was 1.4. Etiological workup was done that showed hepatitis A reactive. Other viral markers were negative. Autoimmune profile was also negative, and serum ceruloplasmin was within normal range. Imaging, as per ALF protocol, imaging was performed. CT had suggestive of mild cerebral edema. Chest CT was suggestive of mild, moderate pleural effusion, bilateral moderate pleural effusion. And CT abdomen was suggestive of minimal free fluid was present. ONSD on the first day was in right eye of 0.60, in left eye 0.58. Transcranial Doppler in right eye pulsatility index was 1.18 and resistive index was 0.77. In left eye was 1.15 and in right eye, resistive index was 0.67. QPI was of in right eye 3 and in left eye also 3. Diagnosis of acute liver failure was made with etiology hepatitis A. Jaundice to HE was of 10 days. He was meeting King College criteria of 2 in among 5. Management, standard medical management was done. Clinical course. On day 1, patient was in HE34. For that, he was intubated and put on mechanical ventilator with FiO2 initially was of 100, which gradually tapered down to the 40. On day 4, patient had sudden cardiac arrest, cause unknown. CPR was started immediately, and after brief cycle of CPR, return of spontaneous circulation was achieved. ONSD monitoring was continued daily, and for cerebral edema, mannitol and 3% NaCl was given. His ammonia decreased from 224 to 134 gradually, and his ONSD gradually decreased from 0.6 and 0.58 to 0.52 and 0.52. On day 5 of admission, patient developed fever. His highest temperature was 100. Antibiotics were recycled as per culture reports. His culture reports were all negative, and PCT also was within normal limit. On day 8 of admission, patient improved clinically and was extubated. Next case is of Miss A, 22 years old female, presented with chief complaints of abdominal pain for last 5 days, loose stools for last 5 days, and jaundice of 1 day. Patient was apparently well 5 days prior when she developed abdominal pain, multiple episodes of vomiting and loose motions with 1 day of jaundice. There was no history of alcohol intake, hepatotoxic drug use, blood transfusion, high risk behavior. Patient had history of anxiety. On examination, her heart rate was 1110 per minute. Blood pressure was 118 by 78 mmHg. Respiratory rate was 22 per minute. Saturation was 100% on room air. Patient was conscious but slightly disoriented to time, place, and person. Ictus was present. On per abdominal examination, dull note was present. Dull note and free fluid was present. Her initial investigations, ABG, pH was of 7.49 with PCO2 of 30 and PO2 of 77, bicarb of 23, and lactate was 6.1. CBC, his hemoglobin was 13.3 with TLC of 6.79 and platelets were 134. LFT was suggestive of with total bilirubin of 6.45 with direct of 4.4, and her AST was 3,800 with ALT of 2,900. KFT was within normal limits. Her initial INR was 3.37 with ammonia of 200. Her ascitic fluid tapping was done, which showed high protein and high SAG. She is also having bilateral pleural effusion, for which diagnostic and therapeutic tapping was also done. Pleural fluid also having high protein of 3.24 with high SPEC of 1.2. USD Doppler was done, which showed hepatic vein patent and ascites was present. Etiological workup was done. Her hepatitis A was reactive, and serum cellular plasmin was low of 0.12. Her 24 hours urine copper was increased of 618.74. Clinical diagnosis of acute on chronic failure was made with acute component of hepatitis A and chronic, likely Wilson disease. She is having low cellular plasmin, high 24 hours urine copper, and neuropsychiatric symptoms in form of anxiety, and with organ dysfunction of cerebral HE grade 1. These are the imaging. CT brain was within normal limits, and HRCT thorax was suggestive of bilateral pleural effusion, right more than left, for which diagnostic tapping was done. Therapeutic as well, diagnostic tapping was done. CT abdomen was showing moderate free fluid. Clinical cause, on day 2, ascitic and pleural tapping was done. There was no spontaneous bacterial empyema or spontaneous bacterial peritonitis. On day 4, in view of tachypnea with respiratory rate of 40 and tachycardia with heart rate of 184, patient was intubated and put on mechanical ventilator. Initially, her FiO2 was 100%. X-ray was done, which suggestive of bilateral mild to moderate pleural effusion. After that, USG screening was done. That's suggestive of bilateral pleural effusion with left consolidation and pneumonic effusion. At that time, X-ray was not available. Blood culture came on day 5, which was suggestive of Salmonella typhi, for which antibiotics were recycled as per culture reports. Patients improved gradually, and on day 10, she was extubated. Currently, she is doing well. Third case, mortality. 19 years old male, resident of Saudi Arabia with no comorbidity. His index event was in March 2025 when he developed abdomen pain, abdomen distension, for which he was evaluated outside and diagnosis of Budd-Chiari syndrome was made. There was no pro-thrombotic workup was available with patient. In June 2025, patient came to ILBS. Further workup was done and patient underwent dips. His pre-dips left were CBC, hemoglobin 16, LFT, total bilirubin of 4.26 with direct of 1.4. AST was 96, ALT 74. Total protein was 5.04 with albumin 3.24. KFT was within normal limits. INR was 1.68. Post dips on 7th of June, his LFT was total bilirubin was 3.12 with direct of 1.5. AST was 76 with ALT 52. KFT was within normal limits and INR was 1.79. He was, after dips, he was started on Clexane, 0.6 ml subcutaneous BD. These are the pre-dips pressures of portal vein was having 28 mmHg of pressure. IVC 0.06 mmHg, right atrial pressure was 3 mmHg. Post-dips pressures were portal vein 14 mmHg and IVC was 8 mmHg. Right atrial pressure was 7 mmHg. Mid-stent pressure was 11 mmHg. This is still from fluoroscopy, suggestive showing IVC with no hepatic vein. They did direct puncture of portal vein via IVC and a stent was placed. Following that, ascites was gradually resolved and patient switched to dabigatran and then stopped on its own. We lost patient from June till January 23, 2026. Patient again admitted on 21 January 2026 with complaints of worsening ascites. On that time, grade 3 ascites was present with worsening jaundice. Bilirubin went up from 3 to 23.7. His examination, BP was 122/68 mmHg and saturation 100% Orogen. Patient was conscious, oriented, time-place person. Pallor ictus was present. On per abdomen examination, distended abdomen was distended. On percussion, dull note was present and free fluid was present. Initial assessment in emergency, his TLC was high, 18,000. INR was 3.63. His initial urea was 174 with creatinine of 6.40. His bilirubin was 23.7 with direct of 11.9. AST was 119 and ALT was 41. His ammonia was 239. ABG lactate was 1.8, otherwise no. Assessment in ICU on day 1, hemodynamic parameters, heart rate was 88 and BP was 122/68 mmHg. IBC was 21/20. His PF ratio was 200 and later in ICU 178 and he was put on HFNC. Metabolic parameters, his lactate was in ICU 2.4. His urine output was nil from day 1 with urea create mildly decreased, slightly decreased in ICU. His diagnostic ascitic fluid SAG was on higher side with sugar 0.43 and protein sugar 96 and protein was 0.43. Albumin 0.22. TLC were 70. Other investigations, his initial blood culture and urine cultures were negative, but subsequent mini-ball was suggestive of Acinetobacter baumannii complex. Aerobic tip cultures of centralines were also showing.
What's your diagnosis of the patient at the second time when he
Ma'am, likely stent block.
his presentation?
Ma'am, worsening of ascites and jaundice.
Is this what he called as presentation and diagnosis? What was the diagnosis when he came here? What is this presentation?
Abdomen presentation was abdominal distension and yellowy discoloration of hygiene urine.
Don't you think the patient had ACLF? Did
Diagnosis.
he have AKI and ACLF?
Yeah, ma'am.
तो कहीं तो आपको डायग्नोसिस पूरी कंप्लीट लानी चाहिए.
आगे. Next slide. On day one, clinical course on day one, his PF ratio was 178 on HFNC. Urine output was 0, nil. Ammonia was 239 with MAP 78. INR was 3.63. Lactate gradually increased to 7.2. On day one, IS screening was done that showed stent block with gross ascites. On day two, nephro consultation was taken. They advised SLAT. Initially, patient started on SLAT, but due to fall of BP, patient converted to CRRT. Day four, DIPS, venogram, and angioplasty was done, and covered stent of 10 into 10 centimeter was placed. On subsequent X-ray, there was right moderate pleural effusion for which pleural tap was done. At that time, HPB surgery opinion was taken. They advised SLKT, but there was no donor available with patient. His laboratory trends, his TLC gradually increased from 18,000 to 41,000. On INR is also gradually increased from 3.63 to 4. His urea and creatinine, initially 174 urea and creatinine was of 6.40. We started on SLAT, then CRRT. So that decreased gradually 91 and 3.34. His bilirubin was initially 23.7 with direct of 11.9, which slightly increased to 25.65 and direct of 15.11. His AST-LT also gradually increased from 119 to 611 and ALT 41 to 168. His ammonia gradually decreased from 239 to 133. His PCT was on increasing trend from day one. It went up to 19.7 on day 15. Sir. On day 10, his blood culture was showing Acinetobacter baumannii complex, for which antibiotics were recycled as per culture. His tips culture also showing same Acinetobacter baumannii. He again developed right sided pleural effusion, for which ICD was placed. And again, ascitic fluid culture, diagnostic ascitic fluid tapping was done. That showed Enterococcus faecium. Antibiotics were recycled as per his culture reports. Gradually, patient is having worsening of stroke despite multiple inotropic supports. He was later he was on NORAD of 38, vasopressor of 2, dopamine of 3, and fenipress of 2. On day 3, patient had cardiac arrest and could not be revived and declared dead on 15th of February 2026. His lactate gradually increased from 1.8 to 7.2. His inotropic demand was gradually increased from NORAD of 6 ml per hour to NORAD of 38, vasopressor of 2, dopamine of 3, and fenipress of 2 ml per hour. Diagnosis, chronic Budd-Chiari syndrome. Status post DIPS. Patient stopped anticoagulant. Following that, there was worsening of ascites and jaundice with new onset of AKI. He presented with AKI stage 3 and stent block with sepsis and sepsis shock. His issues were DIPS block, for which venography and angioplasty was done on day 4. AKI, likely acute tubular necrosis. Patient was anuric from day 1, for which CRT was started. Septic shock, blood and central line cultures all positive for Acinetobacter baumannii. Grade 3 ascites, which showed SBP, and right hydrothorax, for which ICD was placed. He developed later encephalopathy of grade 1 and 2, likely septic plus hepatic as well. The region of ascites in Budd-Chiari syndrome after DIPS, likely sun dysfunction, if or liver function status, if severity of existing fibrosis or cirrhosis may plays a significant role. If the liver parenchyma has sustained severe damage, like necrosis, ascites may persist even with a functional shunt. Anticoagulation compliance, incomplete adherence to anticoagulation therapy can lead to recurrence of thrombosis, increasing portal hypertension, causing refractory ascites. Our patient was not compliant to anticoagulant. He stopped anticoagulant on its own. Management,
Logical profile of this patient?
no.
Why?
Patient was diagnosed outside with.
So,
In last admission, when there was no etiological workup was done, and
why? That's what I'm asking. Why? Etiological workup is, I'm sure, is a part of the protocol for. We do it in LVS, in pediatrics, and it should be done otherwise also.
I think patient is having.
The patient came in ICU with liver failure, but he came 6 months. Actually, old reports were not available with the patient at that time. He was from outside. The CT, MRI was also done from outside, and all the blood reports were also done outside. So at that time, at this admission, the reports were not available with the patient. And the patient was in liver failure, so we did not repeat the test.
Medical management of ascites in diuretics, but our patient was having AKI, so diuretics were not started. But if shunt is failed, reintervention can be done. Issues were advanced liver disease with AKI. We accelerated liver transplantation workup, but sadly there was no donor available with patient. We kept him on continuous CRRT from day 1. Is SLKT possible in this patient? What more could have been done for this patient? AKI with nil urine output from day 1. Patient is having nil output from day 1. We started on CRRT from day 1. Third issue was DIPS block. We did venogram plus angioplasty. The opening of this DIPS is a good idea in this patient. And patient is having persistent MDR infections despite multiple antibiotic were changed on culture base, but patient was having persistent infections. Prevalence and predictors of multi-drug resistant bacteremia in liver cirrhosis. Antibiotics administered within 30 days, or if patient is having admission within 30 days, that increases chances of MDR infection, or patient can develop nosocomial infection during hospital. So my patient likely having nosocomial infection, multi-drug infection.
To conclude now, we are already crossed the time limit. Thank you. The main issues in this was a boy from Saudi Arabia, and the dips was done, and he was doing well. The bilirubin had come down. Then he stopped medication, suddenly showed up in the emergency and goes with a bilirubin of 23. The question was whether we should open up the block dips, which was open, but he had from day one 80, probably ATN, no urine output. So, and no transplant options. So everything was tried. And I think he was a medical student, am I right?
Yes, sir.
He was a medical student, so we worked very hard, but couldn't do. Do we have a post-mortem biopsy, liver biopsy? Was he
This postmortem biopsy was
biopsy of kidney and liver both?
I saw sir yesterday, but report was
नहीं, किसी से discuss कर लेते हैं. So we do not know what more we could have done in him, and despite CRRT, but his create was 6, 5, 4, high ammonia. Nothing more was possible probably than infections. Any other comments? So, transplant teams had also seen, but because of the kidney and no donor. Okay.
Thank you. Thank you.
Good morning, sir. I'm presenting the morbidity and mortality for the month of February 2026 for the Department of HV Surgery and Liver Transplantation. Liver transplant data for February 2026, we done 9 adult LDLT, 1 DDLT, and 3 pediatric LDLTs. So a total of 13 transplants with 1 LDLT in Ames Bhubaneswar. And from starting of this year, we have done a total of 26 LDLT, and there was 1 mortality in 2 months, which was last month. Elective surgeries for February, those 32 cholecystectomies, HJ1, hepatectomy with HJ1, Whipple's 4, hernia 2, Kasai procedures 1, extended cholecystectomy 1, low anti-dissection 1, and lap peritoneal dissection 1. In emergency surgery, there was explorative laparotomy with cholecystomy 1 and 1 tracheostomies. There was no mortality this month. I'll be presenting the morbidities. Morbidity, Mr. RS is a LT of last month. Currently, day 33, he's currently having sepsis-induced graft dysfunction and lung consolidation with positive cultures with raised bilirubin levels. And Mr. RK, I'll be presenting in detail this morbidity. Mr. RK, 62-year-old male, is sarcopenic. He was admitted on 12, and date of surgery was on 12. History, he had an index presentation in 2023. He was instantly diagnosed CLD, so referred to LBS in February 2023. He was managed conservatively initially with medical management. He started having decompensation from 2024 and was controlled on diuretics, the refilling ascites. And in 2025, he had further refilling refractory ascites, for which he had multiple LVPs done, and he was referred for LT in November 2025. And in last hospital admission, he had diuretic intractable ascites. He had a creatinine of 1.74 and hyponatremia of 123. His diagnosis is CLD, SLD with anti-HB co-reactive, with the decompensation of ascites, jaundice, AKI, SBP, and sarcopenia, MEL 3 of 24. These are the immediate pre-op investigations, where uric creatinine was 1.74 and a bilirubin of 6.96. And further preoperative workup, he had severe HPS, severe PV shunting was seen. Donor was his son, 25-year-old male. He had all normal parameters. He had a data box positive with Gilbert syndrome, and he had good volumes. LT was done on 13/2/2026. In intra findings, he had atrial ascites. He had dense additions intraoperatively due to the previous SBP. He had two portal veins anastomosis done, and in drop event he had a redo hepatic artery anastomosis done in drop. His graph weight was 756 with a GRWR of 1.26. Doppler parameters were normal after redo hepatic artery anastomosis. HP was suggestive of cirrhosis, and this is the explant liver with showing change of SBP along with cirrhotic liver. Postoperative course on day 1, day 0, we shifted to ICU on ventilatory support with high inotropic support. And he was exhibited on day 1. Inotropes were tapered to single inotropic requirement. He had adequate urine output and normal lactates. He had normal graft Doppler and graft functions. He had hypertech for which heparin was started. Day 2, he had abdominal distension with high NG drainage. It was mostly related to the SBP changes earlier. Mostly patients present with ileus in the post-op period of 2-3. So X-ray abdomen also showed a picture of ileus. He also had a right effusion for which independent NIV was given. His inotropic supports were fully tapered, and he had a slightly elevated creatinine report of 1.16. His pre-op throat cultures were positive of Klebsiella, and the antibiotics were upgraded. He had persistent ileus, which slowly settled on post-op day 4. He had a low platelet count for which SDPC was transfused, and he was on NIV for the right effusion. On day 4, he was NG feed was restarted. He was tolerating oral liquids, and he was shifted to HDU. And on day 5, he had normal reports, but on the Doppler, he had a low PSV and RI, for which we had done a CCT. But CCT, the hepatic artery was visualized well, and HRCT showed a bilateral pleural effusion. And so he had a hypertech for which we had started a low dose heparin for the patient. On day 6, patient was had a stable graft functions. His heparin was held in view of low platelets. NIV was continued in view of effusion, and his sputum culture also came as MDR Klebsiella, for which it was repeated. On day 7, he had a low-grade fever with hypotension, for which antibiotics and antifungals were upgraded as per culture sensitivity. Cultures were repeated and inotropes were started. He had increased oxygen requirement. X-ray was not available in between. Now, his X-ray showed infiltrates, for which he was shifted to ICU with NIV and HFNO support. On day 8, his inotropes were tapered, but NIV requirement increased, and pulmonary opinion was taken. As cultures came positive for Klebsiella, for which the antibiotics were upgraded. And as per the culture sensitivity of sputum as well as blood cultures. On day 9, he had an episode of GTCS for 6 seconds with post-ictal drowsiness. In view of the poor GCS, patient was intubated, and an SDBS was transfused for low platelet again. His CT brain showed right frontal hematoma, for which neurosurgery opinion was taken and the advice was followed. And his HRCT chest also showed bilateral consolidations, for which pulmonary consult was sought, and we had upgraded the antibiotics accordingly. On day 10, repeat NCCT was done, which showed no expansion of hematoma or any midline shift. And we had done early tracheostomy in view of the neural status as well as the poor lung picture. His FIT was tapered, and inotropics were inotrop support was improved. And on day 11, his sedations are tapered. At present, he has no focal neurologic deficits. He's responding to commands. He was tolerating NG feeds, and he's planned for TP's trial. This was a trend of bilirubin from pre-op to day 11-12. And this is the trend of AST-LT, which is settled. This is the trend of platelets and creatinine. Creatinine was high initially, and he had a persistent creatinine of more than 1. The discussion, patient had and preoperative issues where patient was referred to LT in November 2025. He was sarcopenic, had SBP, multiple hospital admission in the past with a poor fidelity index. Post-operative, he had pneumonia with right frontal ICH. So intercerebral hemorrhage after liver transplantation, the incidence is around 6.5% with a median onset of day 4. Mortality is high of 80%, and the factors like intraoperative transfusions in intraoperative hypertension and coagulopathy were significantly associated with intercerebral hemorrhage. In the data in frontis and neurology, the neurologic complications were common in as high as 35%, and most common picture being encephalopathy. Factors influencing the neurologic complication after LT included pre-op dialysis, HRS, renal insufficiency, intraoperative dialysis, pre-op encephalopathy, and pre-op mechanical ventilation and infection. So pre-op infection was independent factor of any predictor of neurological complications post-LT. We're having IL-based data from 2011 to 2024, in which we in adult out of 693, the neurologic complications seen in 85 patients. In pediatrics, was seen in 7 patients. Most common was in males, and ethanol being the most common etiology, followed by cryptogenic and NASH. And MEL score, 55% of patients had 21 to 30, and ascites being the most common decompensation among the following. And most common neurologic complication was seizure, and that is 34%, followed by intracranial hematoma of 15.3%, 3%, and infarct of 15.2%. 90% of events occurred in the first 30 days, of which 55% occurred in first 10 days. Median ICU stay of 18 days and hospital stay of 32 days with a mortality of 24%. And other independent factors influencing the neurological complications are preoperative HPS, post-op cardiac complications, post-op CMV infections, and post-op day 1 hemoglobin.
Just hold on. It's very important, a good analysis. Do you have any insight into the causes of seizure, or will you tell us later?
Sir, a seizure, one is related to the...
In 1 in 3,
Yes, sir.
no, not 1 in 3, 80 out of 85, 1/3 had seizure. So why?
No, seizure is 34% of the neurological complication.
Yeah, of the 85
Yes,
who had neurological, 34 had seizures.
yes, sir.
Any insight?
One could be related to the in intermittent. We monitor the TAC levels. One is TAC level related. Other being any neurological, any ICH hematomas or
15% ICH
Yes.
are included into this 34%.
just
Because ICH could be a cause or seizure could be, just predisposing to that.
yes, it is role.
Yeah. So this is division of, the first line is division of all the neurological complications.
Yeah.
34, 15, 15. I think this 15% ICH include that in 34%.
Yeah.
That's one of the most common thing. So ICH after transplant, as we can see, it's one of the very common complication. 5% overall in the literature.
5% I thought was.
So this
This is-
15% is because this is of neurological complication. If we take our overall, it will be around 2% ICH.
Agreed. Go ahead.
So that's okay.
Now, one more thing is the outcome of these infarcts. Was there any, muscle or, heavy paresis or something? Was there something?
Yes, sir. There was for this patient, he had no neurological deficits, but we have seen patients having hemiparesis, but they have improved over time with physiotherapy support.
Okay.
So
ICH, it's a frontal ICH. What kind of deficit were you looking for?
Ma'am, frontal ICH has actually lesser
Sure, huh?
muscular deficits. Actually, once patients sensorium wise and everything is looking. If he has good sensorium, he's responding to commands. He's obeying. He's showing numbers.
This is a time we have to welcome our new faculty, Dr. Bhairavi. Are you here? Yeah. So we have a neurologist here who has joined us recently, Bhargavi. So any comments from you, and would you please?
So I've seen quite a few patients with seizures, and many a times I feel a lot of metabolic derangements are leading to seizures, even focal seizures, which I saw in the short period that I have been here. I've seen focal seizures in a few patients, even focal status in patients with no substrate in the brain, but metabolic derangements. So that is something that I have seen. And here they have not specified whether it is focal or not, but then I think both types of seizures can be seen in metabolic derangements that we see here.
Okay. We welcome you and we hope that we get more insight and help from you.
Yes, sir.
Thank you, Bhargavi.
We can
Welcome.
analyze it further.
Thanks.
So one of the important thing is the shift in electrolytes which happens after transplant. That's sodium. Actually, this analysis, this is multivariate univariate, actually showed that if we take delta sodium, then it is associated with increased neurological complication. That's one of the things which we also consistently see. As far as bleed is concerned, the common thing is the combination of thing happens. You have a patient after transplant, they become hypertensive. So once the nitrous oxide is washed out, cirrhotic liver goes out, they become bradycardic and hypertensive, and they all require antihypertensive measures actually in order to control blood pressure. And then you have a combination of a hypertensive patient with low platelets. And in this particular patient, we landed up giving him heparin because he was hypercoagulable as well and on his steg, and that possibly has precipitated his ICH. On top of it, because he had a chest infection, so he was requiring NIV. NIV will raise intracranial pressure as well, and it can bleed as well. So that's what I think might have happened to this patient.
Well managed. Any comments? Gaurav, are you around or anybody from anesthesia, critical care?
Can you go back to that slide, cause of bleed in the series you showed, not your data? So here, prior to this one. So the causes are these. More common causes are these for the post-transplant. Is that right?
All right. Very happy that there are no more.
That's why when we look at the literature, we need to look at very carefully. This is just 77 patient. Our data, just show our data. Just go back to our data. This data actually included 1,000 patient. So, just because 77 patient series versus 1,000 patient, our own data, and we know what are the causes there. Yeah. So we just need to be careful.
We have one more presentation. Thank you. Very well done. Come the pediatrics
Not
presentation.
pointing outside.
Okay. While waiting, we also have a new consultant in liver transplant. Are you around?
She's not here. So
Not
one
here.
thing I wanted to say in this case, the fluctuation in sodium is quite one important cause of seizures. Most of those seizures are because
Yeah.
of fluctuation in sodium.
That's what we need.
Patients with severe hyponatremia before surgery, when there is little bit of overcorrection, even overcorrection followed by undercorrection, both of them are responsible for seizures. So most of the seizures are because of that. Obviously, the intracranial hemorrhage, they will also have seizures. They may have.
Okay.
And this patient has got GTCS basically, but the sodium on that day was almost 150.
Okay. All right, pediatrics, please.
Good morning, respected faculty. I'll be presenting the monthly data from the month of October to January of Pediatric Hepatology Department. In the month of October, November, December, and January, we had an average OPD attendance of 500 patients per day, of which nearly 300 patients were follow-up patients and 250 patients were new patients. Our IPD admissions in the months were nearly 50 to 60 admissions per month. Etiological breakup wise, most of the patients were of chronic liver diseases, acute viral hepatitis, and neonatal cholestasis syndrome. We performed nearly 126 upper GI endoscopies, out of which 50 were diagnostics, 14 duodenal biopsies were taken, and 62 were therapeutic. 10 colonoscopies were performed, 25 liver biopsies were performed. We had two mortality in past 4 months. First was Master M, which I'll be discussing in detail. The second was a 6-year-old female, Miss V, who stayed with us for 5 days. She was a case of acute liver failure with grade 4 hepatic encephalopathy. Etiology was hepatitis A infection. Cause of death was coagulopathy with pulmonary bleed with catecholamine refractory shock. So now I present Master M, 14-year-old male child who was admitted on 26th of October with complaint of fever of 7 days, persistent vomiting of 5 days, and altered sensorium of 1 day. He, on examination, was having a heart rate of 70, hypertension with the BP more than 95th centile. His sensorium was altered. He was combative. His pupils were 4 mm, sluggishly reacting. ONST at admission was deranged, being 5 and 5.1. He had hepatomegaly of 4 centimeters, no splenomegaly, no free fluid, and rest of the systemic examination was normal. His initial investigations revealed anemia, thrombocytopenia, no hemoconcentration, with a AST and ALT of 10,000 and 4,480. His INR was deranged, 4.14. Ammonia was elevated. His etiological workup outside was positive for NS1 antigen. So his initial diagnosis was acute liver failure with hepatic encephalopathy grade 3, KCH2 by 5, etiology severe dengue infection. So when he presented to us in the emergency, we intubated in ER for neuroprotection. Anti-ammonia measures were immediately started. He was shifted in ICU, CRRT was started, and plasma exchange was done. He underwent 2 sessions of plasma exchange. But on day 2, he developed features of septic shock with high inotropic requirement, with inotrope going up to a maximum of inotrope score of 40. His INR gradually improved to post-flex from 4.1 to 2. It stabilized, but because of persistent thrombocytopenia and DIC, he developed multiple episodes of oronasal bleed, gastrointestinal bleed, and pulmonary bleed. All these complications led to increasing mechanical ventilatory requirement, for which the patient was, as per the ROTEM reports, was transfused regularly with platelets, FFP, and cryoprecipitates. These were his X-rays showing bilateral heterogeneous opacities because of pulmonary hemorrhage. Because he was having persistent oral and GI bleed, we did a bedside endoscopy, which did not show any local cause of bleeding. It was just the blood which was trickling from above oral nasal bleed. His HE gradually improved over a week, after which he underwent a tracheostomy. His shock also resolved, but there was a persistent elevation in total serum bilirubin levels, which at admission was 4, and by day 10 and 11, it rose to 23. On day 11 of hospitalization, again, he developed features of septic shock with hyperdynamic circulation, increasing inotropic requirement, and he developed a massive pulmonary bleed, for which bedside video bronchoscopy was done, which showed thick, pale gray blood stain secretions, and he succumbed the same day. If we reviewed the lab investigations during the hospitalization, we can see that AST and ALT were gradually improving. INR also stabilized post 2 sessions of flex, but bilirubin was progressively rising. So the issues for this patient was, since admission, frequent ICP spikes, which was well controlled with propofol and thiopental, active pulmonary bleeding requiring high ventilatory settings, active bleed from nasal cavity and upper GI tract, for which nasal packing was done, upper GI endoscopy was done to rule out any local cause of bleed. Septic shock was managed with appropriate antibiotics, and CRRT and plasma exchange were timely done. So we review acute liver failure, which is a catastrophic hepatic manifestation of severe dengue. Liver involvement has been observed in 74% of the cases. Less than 1% progress to dengue-related acute liver failure. Incidence of acute liver failure in severe dengue is low, but is associated with very high mortality, ranging from 20% to more than 60%. Early recognition of high-risk patients, identification of prognostic markers, and timely supportive and extracorporeal interventions are critical. Although dengue virus is a non-hepatotropic virus, hepatomegaly is commonly seen in dengue, along with the rise in serum aminotransferases, which can be asymptomatic or associated with acute liver failure. Case fatality is as high as 70%. Clinically, liver involvement is seen as hepatomegaly and biochemically raised enzymes. Significant rise in enzyme levels in itself is a sign of severe dengue illness. WHO classifies if AST and ALT as more than 1000 as a manifestation of severe dengue infection. Jaundice and dengue infection has been associated with fulminant liver failure and is a prognostic sign. Mechanism of injury is either by direct viral invasion of hepatocytes, dysregulated immune response, or secondary ischemic injury due to shock, hypoxemia, acidosis, coagulopathy leading to microvascular injury, co-infection with other viruses or bacteria, hepatotoxic drugs, specifically acetaminophen overdose, and because of the decreased excretion of the drugs. On histology, we usually find hepatocyte necrosis, fatty change, cholestasis, and zone-specific injury in severe cases. So if we review the demography, majority of the studies are from the South Asian countries where the dengue infection is most prevalent. Incidence of acute liver failure in dengue is much more prevalent in pediatric group, up to 15% than in adult population. The risk factors are age less than 40 years, persistent nausea and vomiting, elevated serum bilirubin and ALP levels, and more than 10% ratio of atypical lymphocytes, platelet count less than 50%, and baseline MED score of more than 15. Outcome is modified with admission pH, serum lactate, and presence of cirrhosis. All these are risk factors for increased mortality in a child presenting with ALF. Treatment-wise, if we review, then N-acetylcysteine may be used in these patients. Plasma exchange and liver transplantations are one of the few of the modalities which have been used in few patients, but their validity is not well proven. So in dengue, the latest systematic review, which was done in 2024, they showed that the hepatic involvement can just be in the form of elevated AST, ALTs, or hepatomegaly, or acute hepatitis, or just with asymptomatic or abdominal pain. Association of ALF with severe dengue can result in mortality of up to 66%. MELD score more than 15, baseline INR more than 1.5, and rising bilirubin, low albumin, increasing creatinine levels, or are high risk factors for death. In our patient, MELD was 40, INR at admission was 4.1. There was progressive rise in bilirubin, albumin at admission was low, and he required renal replacement therapy throughout his admission. The other predictive factors which have been studied in Indian population, they showed that admission, AST levels, lactate levels, PRISM score, inotropic scores, these are all predictive of increased mortality. And all these parameters were deranged in our patient as well. Acute respiratory failure and active bleeding. These two factors are independently associated with increased 28-day mortality in dengue patients. So management-wise, early monitoring of LFTs and coagulation in all hospitalized cases is mandatory. We should avoid hepatotoxic doses of drugs like paracetamol. Supportive care should be with meticulous fluid intake output, shock prevention and treatment. NAC, the evidence in dengue is limited, but yes, safety is acceptable. Transplant generally is not recommended in dengue-related ALF. When we reviewed the CRRT and therapeutic plasma exchange, then we could find that patients who had undergone TPE along with CRRT, then there was a significantly better outcome, better survival at 28 days than those patients who received only CRRT alone. So to conclude, dengue-associated ALF is rare, but is a severe complication. Early recognition using all these parameters is of paramount importance, so that timely intervention can be done. Extracorporeal therapies, including CRRT and PLEX, may improve the survival, and liver transplantation remains the last resort of therapy due to high risk profile. Thank you.
The patient had improved and then suddenly dipped down.
Yes, sir.
What you could have done better?
So he dipped down because he had a massive sudden pulmonary hemorrhage at that time. For that, the child was put back on ventilator, settings were improvised, and bedside bronchoscopy was also done. If some local cause could be found and any intervention
There is
could be done.
nothing sudden in this. There is something where must be telltale. So you have to look into what was the telltale a day before, what was the platelet.
So he also underwent tracheostomy. He was doing so well.
I know.
Yeah.
That's why I'm saying the morbidity mortality meetings are not to showcase the discussions. It is to look back and get insights into what we could have done better. Now, for example, in this patient, now you see that the platelet counts had improved. If I read correctly, day 11 platelets are 94,000. Am I right?
Yes, sir.
And with this platelet and an INR which had improved from 4 to 1.9, I am a bit worried. I do not know why this patient.
So the PCT, you look at the PCT is gone
Uh,
up. So there is an infection that the child has picked up.
Pulmonary bleed, you have to look into all those things. Maybe
The pulmonary bleed
you have
itself.
a liver biopsy.
No,
You should always have postmortem biopsies for understanding both kidney and maybe even lung. But I should have taken a biopsy. And it-
Somebody should also tell us, I mean, what do you think that could have been done further in this child? We really are at a
Ma'am,
bedside.
I have a question here. Yeah. So did you take the history of any past dengue positivity?
Yes, ma'am. There was no history of previous dengue infection.
Okay. And anybody in the family having a previous dengue infection before the season? This is very, very important. There is known as antibody dependent immune enhancement, and secondary infections are always they cause more severe. Severe dengue does not land up into ALF. Primary infection in a childhood, yes, the probability of ALF, and there's a very huge good data from AIMS, which has come up from the pediatric department, which they have shown that it is the primary infection. So always take a history of primary and secondary, which is important. Sometimes kids, they have a asymptomatic presentation. So having a dengue infection in the family members in the previous season also gives you a hint that the child would have presented. So it's always important to take the family history of the dengue infection. Did you not get the viral load done? Because there are papers which have shown that higher viral load is associated, although you cannot do anything about it, but sometimes they have tried ribavirin. So you should have got a viral PCR also done. And try to identify the serotype, because in Delhi right now with the data we have dengue T2 and 3, and most of the times they're co-circulating. So co-infection by two serotypes together also lands up into a more severe.
Ekta, with that, those two things that you're talking about, the serotype as well as the,
I hope you're collecting all samples.
But you can give more, you don't have antiviral, but you can do more aggressive management.
we were doing aggressive management. He just seemed to have improved out of it and then suddenly went down. That is what I'm trying to ask. What could we have done to avoid that pulmonary hemorrhage? Is all I have a.
With plasmapheresis, just if you cool down your mind and just think about it, that this may be the lung problem, may be just strongly associated with plasmapheresis. And that is what, once you have a trolley, then they are at a high risk of pulmonary hemorrhage. So, although you've shown single slide where TPE and CRRT combination has benefited, I don't know what is the details of those data, because you bring in one slide and show something on a curve, it doesn't make sense to us. We really need to look into closely whether plasmapheresis and how many sessions were done on this and where they were really needed at that time. Because, in an acute injury, if you're doing plasmapheresis, they wash out the hepatic regenerative factors as well. So you need to be very careful in terms of selecting those patients. And this may be just secondary injury because of plasmapheresis, which has led to sepsis later on in the lungs because of alveolar hemorrhage.
The plasma exchange were done in first 2 days.
The
Yeah.
plasma exchange were done in the initial 2 days,
I-
and after which the child improved. He came off inotropes, his HE improved, and we could customize the patient. And secondly, the studies done till date on combination of CRRT and plasma exchange, they have shown the odds of survival much, much significantly higher with the combined therapy than with only CRRT. The
Okay.
mechanism being the removal of all the cytokines which are produced in dengue infection.
PCT has increased, which is also cause of worry. Okay.
Sir, all the more the sequential infection, if it happens by two different serotypes, the cytokine.
I know. Yeah. Okay. Thank you. The first 2 days, but there was a gap of 5 days. So I think, yeah, okay.
That's